So little about the exam mastery live classes, which we have started since June 5th. It is for about duration of 30 days, where we are doing a rapid revision of all important questions. And we will also do quick revision of volatile facts, and all high-yielding topics we'll be dealing with of all the subjects. And here, most expected questions in each topics will be covered. So this is beneficial for all the university exams of all the states. Okay, so you can use the code Dr. Divya 20 for the first free live class. So the core features of Auricle include the live classes, recorded classes, which you can access anytime, anywhere. And we also give you a comprehensive book, which is based on CBME-based question and answers. And there are MCQs, which are from the beginner level to the expert level. So they're all standard multiple choice questions, which are asked in the university exams. So we have 3 subscription plans here: basic, standard, and mentorship. Mentorship is a 12 months 4-term program, which we offer you at a special discounted rate of 50,000. So here, including the other services here, we also give you one-to-one personalized guidance as well as notes. And you can use the code of Divya20 for discount on the subscription. You can book a slot for personalized counseling session on Auricle app. And you can use the code of Divya20 for the first free live class. So we shall begin with today's class. So the first topic being palatine bone. So the palatine bone, here you can see the palatine bone, this one, which is colored orange. So it is situated at the back, okay? So that is posteriorly, it is situated in the back of the nasal cavity between the maxilla and the pterygoid process. So these are the pterygoid processes. This is the maxilla. This is the palatine process of maxilla. So between that and the pterygoid process, here we have the palatine bone. So it contributes to the walls of 3 cavities. That is, it contributes to the floor of the nasal floor as well as the lateral wall of the nasal cavity, the roof of the mouth here you can see, and the floor of the orbit. So it contributes to all the 3 cavities. So it enters into the formation of 2 fossae. That is, it also contributes the formation of 2 fossae. That is the pterygopalatine. Basically, it forms a communication from here to there through the fissures. So that is to the pterygopalatine and pterygoid fossa and fissure, the infraorbital and the inferior orbital fissure. Okay, so that is basically, it will enter into the formation of these 2 fossae, that is the pterygopalatine and pterygoid fossa. So palatine bone also, it consists of basically a pyramidal process, orbital process, and a sphenoid process. Okay, so it will have 3 processes: the pyramidal, orbital, and sphenoid process. A smaller opening nearby, that is the lesser palatine foramina. So here there will be a small, that is at the posterior side here, there will be a small opening. Okay, so at this point, so that is known as the lesser palatine foramen, which transmits lesser palatine nerves and vessels to the soft palate and the tonsils. The spinopalatine foramen, okay, spinopalatine foramen. So you can see here the lesser palatine foramen. Okay, so at this point. So the spinopalatine foramen, basically it's opening between the sphenoid bone and the orbital process of the palatine bone. And it opens into the nasal cavity and gives passage to the branches from the pterygopalatine ganglion and the spinopalatine artery from the maxillary artery. Okay, so this procedure, TESPAL, that is transnasal endoscopic spinopalatine artery ligation, is done in epistaxis due to spinopalatine artery injury. Next, coming to the hyoid bone. The hyoid bone is a U-shaped structure. Okay, so it is located in the anterior neck. Okay, it lies at the base of the mandible, that is at the level of C3 vertebrae. So this hyoid bone has got a body, 2 greater horns, and 2 lesser horns, a pair of greater horns and a pair of lesser horns. So the body is the central portion. So if you see, this will be the body will be the central portion. Okay, central portion. And it has an anterior convex surface and a concave posterior surface. The greater horn will be projecting from each end of the body in the posterior, superior, and lateral direction. So if you see here, this will be the greater horn. Okay, so posteriorly and superiorly in the lateral direction, it will be projecting. Okay, and lesser horn arises from the superior aspect of the hyoid bone near the origin of greater horn. Now, the attachments. Okay, so for the oral cavity and the pharynx, we have the middle pharyngeal constrictor, hyoglossus, as well as genioglossus muscle are attached to the hyoid bone. Then the suprahyoid muscles, that is digastric, stylohyoid, geniohyoid, and mylohyoid are also attached. And infrahyoid muscles are sternohyoid, thyrohyoid, and omohyoid. The ligaments which are attached to the hyoid bone, there are three main ligaments, that is stylohyoid, thyrohyoid, and hyoepiglottic ligament. So they basically act to support the position of the hyoid bone in the neck. Okay, so hyoid bone is usually injured in homicidal associated strangulation. So you can see this is the lesser horn, this is the greater horn of the hyoid bone, and this is the body of the hyoid bone. So from this greater horn, we can see the attachments of the middle constrictor, hyoglossus muscle, the thyrohyoid, and here in the body, we have the stylohyoid, mylohyoid, and omohyoid superior belly is attached there. Okay, so here the geniohyoid and genioglossus muscles are attached. Okay. Next, coming to the scalp. So scalp is what? It is the soft tissue covering the cranial vault. Okay, so that is known as scalp. So that is first definition you need to know. So what is the extent? So anteriorly, it will extend from the supraorbital margin, but it doesn't have any bony attachment anteriorly. Posteriorly, it extends up to the external occipital protuberance and superior nuchal lines, and on each side to the superior temporal lines, okay, where it is attached to the bony surface. So this scalp is made up of 5 layers. Okay, so we have the spelling of the scalp itself is the mnemonic for the layers of the scalp. Okay, so S is for skin. So skin here is hairy. So you need to explain a few features of each layer. So skin is hairy, it is adherent. So it is actually thin skin, which is hairy. It is adherent to the epicranial aponeurosis to the dense superficial fascia. That is, through the second layer, connective tissue, it is attached to the aponeurotic, that is the third layer. It has more sweat glands and sebaceous glands, and it is also highly vascular. Then the superficial fascia, it is more fibrous and dense, okay, in the center than in the periphery of the head. And here the superficial fascia will have many blood vessels, and it binds the skin to the underlying aponeurosis and provides some medium for the passage of vessels and nerves. Then the third layer is the aponeurotic layer, okay, with the occipitofrontalis muscle. So here it is freely movable on the pericranium along with the overlying and adherent. So basically the first 3 layers, they are adherent to each other. Anteriorly, the aponeurosis, it receives the insertion of the frontalis muscle, and posteriorly it receives the insertion of occipitalis. And it is attached, which both these muscles, no, they are attached to the, to the aponeurosis. And in turn, this occipitalis is attached to the external occipital protuberance, and the highest superior nuchal lines in between the aponeurosis will extend there. Okay, so where the occipitalis will have the origin from the superior nuchal lines. And on each side, this layer is attached to the superior temporal line. Then the fourth layer is called as the loose areolar tissue layer. So this loose areolar tissue layer, it is made up of loose areolar tissue. So this layer, no, anteriorly the scalp has no bony attachments. So that is why it extends, okay, along with the layers of the face, that it extends into the eyelids. Posteriorly, it is attached to the highest and superior nuchal lines. And on each side, it is attached to the superior temporal lines. Okay, so what happened? And this loose areolar tissue layer, it has these emissary veins which connects the extracranial veins to the intracranial venous sinuses. So why they connect is basically to maintain the pressure. Okay, so to maintain the pressure difference, that is basically between the balance the pressure, okay, basically between the external and internal veins, that is external, extracranial and intracranial veins. Then the last layer is pericranium. So unlike the other layers, this is attached to the surface of each bone of the cranial vault, okay. So along the sutures, wherever sutures is the joint between the cranial bones. So it is firmly adherent to the sutures where the sutural ligament binds the pericranium with the endocranium, okay, that is inside. So it becomes continuous near the sutural lines with the inner endocranial layer. Okay, next is the superficial temporal region. So it is area between the superficial temporal line and the zygomatic arch. So this area has got 6 layers, that is skin, superficial fascia, the extension of the epicranial aponeurosis, which gives origin to the extrinsic muscles of the auricle, then temporalis fascia, temporalis muscle, and the pericranium. So coming to the arterial supply of the scalp and superficial temporal region. Okay, so scalp anterior supply. So in front of the auricle. So basically, we divide the scalp into anterior quadrant, which is in front of the auricle, and posterior quadrant, by which we mean behind the auricle. So in front of the auricle, we have supratrochlear, supraorbital, superficial temporal. Okay, the supratrochlear and supraorbital are branches of the ophthalmic artery, which are given by the internal carotid artery. The superficial temporal and superficial temporal branch, it is from the external carotid artery. Behind the auricle, okay, we have posterior auricular and occipital arteries, which are from the branches of the external carotid artery. Okay, so here you can see we have the supratrochlear and supraorbital. They are coming from the ophthalmic artery branch of internal carotid. And here we have the superficial temporal artery. So this side in front of the ear, we have 3. Behind, we have the posterior auricular artery and occipital artery. Next, venous drainage of the face. So venous drainage of the face, what happens is the superior trochlear vein, okay, superior trochlear vein will join with the orbital vein. So just like how the arteries are, corresponding to that, there are veins. So the supratrochlear and supraorbital here will join to form the angular vein, that is at the medial angle of the eye. So this angular vein will continue as the facial vein and joins with the anterior division of retromandibular vein. Okay. And when it joins, it becomes common facial vein. And this common facial vein will open into the internal jugular vein. The superficial temporal vein, that is from behind, superficial temporal vein, it will join the maxillary vein. So this from supratrochlear vein, no, it is from the anterior quadrant, okay? Whereas the posterior quadrant part, that is the superficial temporal vein, joins with the maxillary vein, okay? That will form the retromandibular vein. Retromandibular vein will be forming anterior and posterior. So anterior was joining the common facial vein, the facial vein to form the common facial and then draining into internal jugular, right? So this posterior division, it joins with the posterior auricular vein and drains into the external jugular vein, okay? So basically it forms the external jugular vein, that is with the union of this one, what is that? Posterior auricular vein and the posterior division of retromandibular vein, they join together to form the external jugular vein. And most posteriorly in the occipital region, the occipital veins, they drain into the occipital venous plexus, which are connected by the emissary veins, okay? And also drains into the external jugular. So from there. Then coming to the lymphatic drainage, so the anterior part of the scalp drains into the preauricular or parotid group of lymph nodes situated on the surface of the parotid gland. Okay, and posterior part of the scalp drain into the posterior auricular or mastoid and occipital group of lymph nodes. Okay, so when you write the answer for nerve supply, you can write like this: nerve supply of the scalp. Okay, so in front of the auricle, there are 4 sensory. So in front of the auricle, there are 4 sensory and 1 motor. Behind the auricle, again 4 sensory and 1 motor. So sensory, they are supratrochlear, supraorbital, zygomaticotemporal, and auriculotemporal nerve. Okay, motor is the temporal branch of facial. Behind the auricle, the sensory are greater auricular, then lesser occipital, greater occipital, and third occipital. And the motor is posterior auricular branch of facial. Okay, so that is how they will come. So in front, it's basically the sensory nerves are coming from the trigeminal nerve, whereas behind it is coming from the cervical nerves. Okay, so now we will see this one MCQ. So it is asked, man of about 30 years comes to an OPD with inability to close his left eye, tears overflowing in the left cheek, saliva dribbling from his left angle of the mouth. What is the condition? Okay, so almost the entire one half of the face they have described, that is not able to close his left eye. Tears are overflowing on the cheek also. Tears, he can't close his eyes. So because of that, tears are overflowing on the left cheek as well, and saliva is dribbling from his left angle of the mouth. So from the forehead region up to the angle of the mouth, the whole one half of the face is affected. So when one half of the face is affected, we call it as the lower motor neuron lesion. So lower motor neuron lesion is otherwise a facial nerve, is called as the Bell's palsy. Okay, infection in the dangerous area of the face. Okay, infection in the dangerous area of the face. Okay, it leads to which one? It leads to cavernous sinus thrombosis. Now, why cavernous sinus thrombosis is because near the face, okay, it is drained by the deep facial and the facial vein. Okay, and the veins in the face region or in the head and neck region, they do not have valves. Okay, because they are flowing towards the gravity. It's not like against gravity, right? So that is why there are no valves. So because of that, what happens is now this deep facial vein is connected to the pterygoid venous plexus, and pterygoid venous plexus are connected to the cavernous venous sinuses through emissary veins. So because of that, there will be, if there is an infection in the dangerous area of the face, what happens is this infection can spread to the cavernous sinus through this route, that is deep facial vein, and from deep facial vein to pterygoid venous plexus, from pterygoid venous plexus to emissary vein, and emissary vein to cavernous sinus. Okay, so it's like a retrograde spread. So that is what it is. Then supraorbital artery. Supraorbital artery is a branch of ophthalmic artery, which is in turn branch of internal carotid artery. Which of the following nerves ascends along with the occipital artery in the scalp? Okay, which nerves? So with the occipital artery, it will be the greater occipital nerve. Then you have to write about clinical anatomy for scalp. So one is wounds of the scalp. Okay, so it gives when the epicranial aponeurosis is divided transversely. Okay, so because it is all very adherent, there will be a large gap. Okay, even a small wound can cause a very large gaping there in the scalp. And it also bleeds very profusely. Sebaceous cyst. So the scalp here, since it has hair, it is like, hair is in abundance on the scalp. Hair is always associated with sebaceous glands. Okay. So this sebaceous glands can get infected sometimes, forming the sebaceous cyst. Then bleeding. Bleeding here, what happens is the connective tissue will be transmitting these blood vessels, cutaneous blood vessels. So if there is a wound, okay, if there is a lacerated wound or a tear in the scalp, what happens? It will bleed very profusely because the vessels here, they cannot retract by the fibrous fascia because it is adherent there, and it is not able to retract. So bleeding, so how will we arrest the bleeding? We'll basically apply pressure at the site of the injury by a tight cotton bandage against the bone. So we will hold it like that for about 3 to 5 minutes, and by then the bleeding would stop. Cephalometoma. So pericranium, as I said earlier, the pericranium is attached to each of the bones along the suture lines, and it becomes continuous with the endosteum. Okay. So collection of fluids deep to this pericranium is called as cephalhematoma, and it takes the shape of the bone. So if it is confined to the parietal region, it will take the entire shape of the parietal bone. and it will appear like a swelling there, like a parietal swelling there. Okay. So, okay. So that is known as cephalometoma. Then dangerous area of the scalp. Dangerous area of the scalp is the fourth layer, that is the loose areolar tissue layer. Okay, so why it is called dangerous layer is because in this layer, there are emissary veins which connect the extracranial veins with intracranial veins. And these emissary veins, they have valveless, means they do not have valves. So the blood can flow in either direction. And that is mainly because to maintain the pressure, equilibrium of pressure between the extracranial and intracranial veins. So here, because of that, if there is any infection outside because of trauma in that layer, it can spread through these emissary veins into the cavernous venous sinuses. Okay, they are not only cavernous, all the dural venous sinuses it can, sinuses it can spread, not sinuses, sinuses it can spread. Okay, so that is why that loose areolar tissue layer is known as the dangerous area of the scalp. Coming to the face, okay. So muscles of the face. The muscles, the facial muscles, they are basically subcutaneous muscles, okay. So in the face, no, see, generally when we see in most of the body parts, we will have skin, superficial fascia, then there is deep fascia, then there are muscles, then deep to within the muscles and deep to the muscles, we have the vessels and nerves, then comes the bone. That is how the tissues are arranged. But in the face, what happens? The deep fascia is absent because these muscles, facial muscles, are directly inserted into the skin. Okay, so subcutaneously. So these muscles, they develop from the mesoderm of the second branchial arch. Okay, so second pharyngeal arch or branchial arch, the mesoderm of it forms these muscles of the face. Morphologically, they represents the remnants of panniculus carnosus. So panniculus carnosus is subcutaneous muscle. So this panniculus carnosus, no, we see it in cows and all, basically animals, like especially in cows, you see that long thing hanging beneath the neck, right? So that is present. So basically why there that in animals it is very prominent is like animals cannot use their limbs, especially the forelimbs, as like how we use our upper limbs. Okay, they cannot use it in the same way for finer movements. So if there is like a fly or some insect sitting on the animal, okay, it cannot lift its foot and shoo away that, right? So for that, what happens is when it some insect or something sits on that or fly sits on it, this muscle, no, it will immediately it undergoes contraction. Okay, so because of that contraction, that fly or something it will chase away. So that is how it helps in animals. Okay, in humans, what happens? We have evolved and all these things. We have hands for finer movements. So we don't need as such these panniculus carnosus. Okay, so those it has, but these facial muscles, since they have the origin from the that is basically they are subcutaneous. Okay, we consider to be the remnant of the panniculus carnosus. Okay, so they are muscles. So muscles of this face, no, according to the region wise, they are classified. Okay. So we have around the mouth. So we have buccinator. So buccinator has the origin from the alveolar process of maxilla as well as the mandible, and it blends into the fibers of the orbicularis oris. Okay. So buccinator, what happens is it splits into three layers: upper, middle, and lower. So upper layer continues with the upper lip, that is orbicularis oris. And lower fibers also continue with the lower lip. Whereas the middle fibers, no, they will crisscross. Okay. So what they do is the lower fibers go to the upper lip and the upper fibers go to the lower lip. So that is what. So when it contracts, it basically compresses the cheeks, or it helps in the blowing. Okay. Buccinator muscle. Depressor labii inferioris. Depressor labii inferioris is between the mandible. Okay, so in the anterior midline and the mental foramen. Okay, in that position we have the depressor labii inferioris. So basically depressor labii. So to the skin it depresses. No, so that is why to the lower lip. Okay, skin of the lower lip, it will depress the lip. Then levator labii superioris. So here as the name's levator, it will elevate the lip and it is present superiorly. Okay. So it is attached, it has the origin from the lower margin of the orbit, superior to the infraorbital foramen. Okay. So just below the, we have the infraorbital foramen. Just above that, it will have the origin. Okay, so all these oral muscles all around the mouth, the muscles are all attached to the around the orbicularis oculi. Okay, so this elevates the upper lip. Mentalis muscle, it comes from the incisive fossa of the mandible. Okay, it's a smaller muscle here, and it gets inserted into the skin on the cheek. So what does mentalis do? Mentalis will help in elevating and protruding the lower lip. Okay, elevating and protruding the lower lip. We have orbicularis oris. Orbicularis oris is has the origin from the maxilla and the mandible, and it gets inserted into the lips. It compresses. Okay, so orbicularis oris, you can compress like that. Okay, squeeze in like compressing, and you can also purse the lips. Okay, when we purse the lips means when you basically bring both the lips together, we call it as pursing the lips. So rhizorius. Rhizorius has the origin from the fascia covering the parotid salivary gland, and it gets inserted near the angle of the mouth. Okay, so rhizorius, like, it pulls that angle like that. So that is why it's called as the smiling muscle, rhizorius. It draws the corner of the mouth to the side like a whole wide smile. Then depressor anguli oris. Depressor anguli oris, here it is coming from the now this is depressor anguli. Earlier we said depressor labii, okay? So anterolateral surface of the mandibular body, and it gets inserted into the angle of the mouth. So it depresses the corners of the mouth. Then zygomaticus, major and minor. Zygomaticus, it comes from the zygomatic bone near the zygomatico-maxillary suture, gets inserted near the angle of the mouth. It retracts and elevates the corner of the mouth. Okay. The zygomaticus minor, zygomatic bone posterior to zygomatico-temporal suture. Okay, zygomatico-temporal suture. So it gets inserted into the upper lip. It also retracts and elevates the corner of the mouth. Then we have muscles. So these are all like, muscles around the mouth, muscles around the eyes. So what you need to remember is this buccinator is very important. So you need to remember the origin, insertion, action of that. Then around the eye, we have levator palpebrae superioris and orbicularis oculi. Okay, levator palpebrae superioris is from the tendinous band around the optic foramen, and it gets inserted into the upper eyelid. The orbicularis oculi, it is from the medial margin of the orbit, and it gets inserted into the skin and eyelids. It helps in closing the eyes. For the nose, we have one muscle, the procerus. Okay, so nasal bones. So it has the origin from the nasal bones and gets inserted there. So it moves the nose. Okay, so basically brings about the moving in the sense like, when we are trying to pull in like, to the nose like that. So when we do that, there is a contraction, right? So that is brought by procerus. Along with the other muscles, of course, there we have the compressor nares, depressor nares, depressor nasal septi. Okay, so all those muscles will help. Okay. The nasalis muscle has the origin from maxillary bone and alar cartilages of the nose. So here it gets, the nasalis muscle gets inserted into the bridge of the nose. So it compresses the bridge, depresses the tip of the nose, and elevates corners of the nostril. Then around the ear muscles are extrinsic muscles, that is temporoparaitalis. It has the origin from the fascia around the external ear, and it gets inserted into the aponeurosis. Okay. And basically it tenses the scalp and moves moves the spin of the ear in everybody. See, this muscle is actually a appendage muscle. Okay, so it is not necessarily very well developed in everybody. So in some people where it is well developed, they are able to move the ear. You would have noticed how they move the ear up and down or front and back like that. Okay, so those people where this muscle is little active state, it can do those movements. Then other muscles is of the scalp. We have the frontalis muscle, has the origin from Gallia aponeurotica. It gets inserted into the skin of the eyebrow and bridge of the nose. It raises the eyebrows. Okay, it raises the eyebrows when we do like this. It raises the eyebrows. And when we raise the eyebrows, there will be wrinkles formation on the forehead, right? So it wrinkles the forehead. Then occipitalis. Occipitalis muscle has the origin from the superior nuchal line. Okay, and it has the insertion into the aponeurosis. So what does this do? It will tense and retract the scapula. Tenses and retracts the scalp. Then the neck muscle is platysma. Platysma muscle here has the origin from the upper thorax. So in the pectoral region also you would have studied about platysma, right? So upper thorax between the cartilages of the second rib and acromial process of scapula. It has its origin, that is, and it gets inserted where? To the mandible and the skin of the cheek. So it tenses skin of the neck and it will press the mandible. Next, openings in the face. So openings in the face means which are the three main openings there. We have the palpebral fissure, oral fissure, and the nostrils. So each of this will have a okay, so it will have a single compressor. Okay, it has a compressor and many dilators. So each of these the fissures, okay, so they will have compressors. Compressors is basically helps in closing. Now we have the orbicularis oculi, it will help in closing, whereas levator, palpebrae superioris, then corrugator, supercilii muscle, they all help in the dilatation. Same way in the nose, compressor nares will compress, whereas dilator nares, they will dilate, okay. And oral cavity, we have the orbicularis oris, which will compress, help in closure of the mouth, whereas the other muscles around it will cause dilatation or open. So cutaneous nerves of the face. Okay, so cutaneous nerve of the face, when we see, they are basically mainly from the branches of trigeminal. Okay, so the trigeminal nerve will give three divisions. That which one? The ophthalmic, maxillary, and mandibular. So the cutaneous nerves come from there. So from the ophthalmic division, we have 5 nerves. Okay, so supratrochlear, supraorbital, then we have lacrimal, infratrochlear, and external nasal. Okay, so that is the thing. So supratrochlear around upper eyelid and forehead it supplies. Supraorbital upper eyelid, frontal air sinus and scalp it supplies. Lacrimal nerve to the lateral part of the upper eyelid. Infratrochlear nerve to the medial parts of both eyelids it supplies. And external nasal nerve. External nasal nerve will supply the lower part of the dorsum of the nose and the tip of the nose. Then maxillary division. Maxillary division gives 3 branches. Okay. That is infraorbital nerve, zygomaticofacial, zygomaticotemporal nerve. So the infraorbital nerve supplies the lower eyelid, side of the nose and upper lip, whereas the zygomaticofacial nerve will be supplying the upper part of the cheek. And zygomaticotemporal will supply the anterior part of the temporal region. Then next we have the mandibular division of the trigeminal nerve. So mandibular division of the trigeminal nerve, okay, it also gives 3. One is auriculotemporal, buccal, and the mental nerve. So here the auriculotemporal nerve, it supplies the upper 2/3 of the lateral side of the auricle and also in the temporal region. The buccal nerve, it supplies the skin of the lower part of the chest, cheek, okay, skin on the lower part of the cheek. And the mental nerve, it supplies the skin over the chin. Okay, in addition to that, there are some nerves from the cervical plexus, like anterior division of great auricular nerve, upper and lower divisions of transverse cutaneous nerve of neck, lesser occipital, and supraclavicular. So skin over the angle of the jaw, okay, skin over the angle of the jaw and over the parotid region is supplied by the anterior division of great auricular nerve, whereas the upper and lower divisions of transverse cutaneous nerve of the neck, okay, that will supply the lower margin of the lower jaw and upper part of the neck. Lesser occipital, it supplies the back of the auricle, and supraclavicular, it will supply the front of the thorax till the second costal cartilage and the skin over the upper half of the deltoid muscle. Okay. Okay. So nerve supply of the face. Nerve supply of the face, we have the motor and the sensory. So sensory we already saw. This was the cutaneous innervation of the face. Motor nerve is mainly by the facial nerve. Facial nerve gives 5 terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Cervical, it's not shown here. Cervical will also be there. Okay, so temporal, zygomatic, buccal, mandibular, and cervical. So basically, they come like, the 5 fingers, or the pes anserinus, we say. That is basically the branches of the facial nerve and the connective tissue in between. It gives an appearance of a webbed feet and duct. Okay, so that is why it is called as pes anserinus also. Sensory is trigeminal nerve. Through its 3 branches, it will supply. Okay, so you can see these are the branches of the sensory, that is trigeminal, and these are the branches from the facial. Only one thing you have to remember is in the neck, in the head and neck region, okay, the skin over the angle of the face, that is supplied by this one. That is greater great auricular nerve. Okay, it's senior. So great auricular nerve will supply near the angle of the mandible. Okay, so how do we examine the facial nerve? The facial nerve is examined, okay, by testing the muscles. Which muscles do we test? First is frontalis. So how do we test it? We ask the patient to look upwards so we'll ask them to sit stable, okay, and just look up like this. So when they look up, what happens? There will be horizontal wrinkling on the forehead. So if that is there, that means that muscle has its power to go do that, and the facial nerve is intact there. Okay. Dilators of the mouth. So we use dilators. Dilators of the mouth means like, opening the mouth. So what do? We ask them to clench the teeth like that, just clenching the teeth, showing the teeth. So that means those muscles are also have the power. Then orbicularis oculi. So orbicularis oculi, we ask the patient to tightly close the eyes. Okay, tightly close the eyes. Buccinator. Yeah, so buccinator, we'll ask the patient to puff their face. Okay, so they have to fill their mouth with air, and like that they have to puff. Okay, so that will indicate, okay, that the facial nerve is functioning properly and these muscles are all supplied properly. Okay, then we ask them, even buccinator is tested by asking them to whistle, okay, or blow the hair out. Okay, that is also done. So this is the C. Here we are testing. Facial nerve, the special functions of facial nerve. So in the face, outside, externally, it is mainly motor, no? But inside, no, the facial nerve is also sensory. So here what it is doing, it will carry its taste sensations. Okay, so that is why what do? We ask the patient to protrude the tongue and ask them to close the eyes, and without their knowledge, we just drop some, like we tell, we will be dropping. So you need to tell the taste. So we will, like you can put some bitter or salt or sugar or anything and ask them to say. Okay. Then this is raising the eyebrows. So frowning, that is corrugator supercilii, I told you, no? And wrinkle nose. So lesions of the facial nerve. Facial nerve lesions can be supranuclear or intranuclear. Okay. Supranuclear means, see, the nucleus of the facial nerve, it is in the pontomedullary junction, okay, in the pons it is. So the facial nerve, mainly when we are talking about the face, it is supplying motor. So when it is supplying motor, the highest motor center is in the cerebrum, right? So from there begins the corticonuclear tract. So corticonuclear tracts come to the nucleus of the facial nerve. Okay, so this facial nerve nucleus, when it comes, these fibers, we call it as the supranuclear fibers. And from this nucleus, what happens is the fibers begin, okay, that is forms the facial nerve, and then it will supply the face. Okay, so that is the main pathway. But here what you have to remember is, now see, this is right side, this is left side, right? This is the face, so right side of the face and left side of the face. Now, when we see here, the right corticonuclear fibers, most of them are crossing over to the other side. Okay, and this one from the left side is coming towards the right side. Okay, so they are basically crossing. But there are certain fibers which will go straight without any crossing. Okay, that means the right side will supply only right side, left side will supply only left side. So that now, if there is a lesion, okay, supranuclear lesion, I hope it is clear till here. So now supranuclear lesion means this is the nucleus. So above the nucleus, there is a lesion. Now there is a lesion here, no, okay, on the left side. So this is called as the upper motor neuron lesion. Okay, upper motor neuron lesion or bulbar. Okay, so supranuclear lesion we say. So here now, these fibers, now left side, most of them are crossing to the other side, isn't it? But there are few fibers which are going on the same side. Now these fibers which cross over the other side, where they are supplying, that is the right half of the face they are supplying. Whereas the fibers which are going same side downwards, okay, same side downwards, will be supplying the upper part of the forehead. Okay, you got it? So the opposite fibers, they will cross over, go to the nucleus, no? So from there, the facial nerve will begin. It supplies the whole half of the face on the side. Right side nerve will supply the right side, left side will supply the left side. The fibers which do not cross, okay, so do not cross, will supply the same side only, but the forehead region. Okay. So that is why in upper motor neuron lesion, what happens is upper half of the face is spared and only the lower half is affected. This is upper motor neuron. But whereas lower motor neuron, what happens? The entire face is affected. Okay, because here lower motor neuron, no? Lower motor neuron lesion or infranuclear lesion means below after it crosses over. So after it crosses over, it is supplying the same side. So if we just cut it off here, that means this nerve, okay, the facial nerve, which are actually carrying most of the fibers from the left side, is cut. Okay, so that time it is affecting the right. Left side fibers are supplying the right side, right? So right half of the face will be affected. The same way, if it is right lesion here, as shown in the picture, it is right side, left side. So because of that, the right side fibers which are crossing over are affected, and it will affect the whole of the face. So how we differentiate, okay? So supranuclear lesion, when we ask them to wrinkle, okay, it will be intact. Whereas infranuclear lesion, everything is lost, okay? They'll not be able to close their eyes also in the infranuclear, here they are able to. Okay, here there is ataxia, here there is no ataxia. Facial palsy is there, here there is, it's not affected, that is no hemiplegia is there. Then reflexes are intact here, here there are no reflexes. Tone is maintained, tone is flaccid here, drooping corner of the mouth. Okay, there it may not be an associated feature. Slight flattening of the nasolabial fold can occur, but here it is not an isolated finding. No muscle atrophy is there. Muscle atrophy or fasciculations may be present. Okay, so and the sensory distribution of the trigeminal nerve. Trigeminal nerve, you saw how it divides into the three divisions: ophthalmic, maxillary, and the mandibular. Okay, so that is why the sensory distribution, it will explain headache is uniformly a common symptom involving the paranasal sinuses, infections, and inflammation of teeth. Okay. of the teeth and gums, infections and inflammation. That is not inflammations, it is inflammation of teeth and gums. Okay. And refractive errors of eye, infection of the meninges can also affect. Trigeminal neuralgia is basically it involves one or more divisions of trigeminal nerve. Okay, usually the ophthalmic and mandibular be affected. So that time what happens, there will be it will be painful in the region of that supply. Okay. So it is usually you can cause severe burning and scalding pain along the distribution of the facial nerve. So along this distribution, wherever it is supplying, there will be very much pain. Okay, so facial vein, when we say facial vein is the largest vein of the face and it doesn't have any valves. It begins as the angular vein near the medial angle of the eye by the which is angular vein is formed by the union of supratrochlear and supraorbital veins. Okay, so this angular vein will continue as facial vein. So it will run downwards, backwards and behind the facial artery, and it crosses the anterior-inferior angle of the masseter. Okay, so it is pierced by deep fascia and it crosses the submandibular gland like this. So basically in the submandibular gland, the superficially lying structure will be the facial vein, deeper will be the facial artery. And then after that, it joins with the anterior division of retromandibular vein below the angle of the mandible, and it forms the common facial vein. And okay. So, and it finally drains into the internal jugular. So these are the headings under which you can write. So what are its communication? It communicates with the supranuclear and supraorbital and superior ophthalmic vein. Then it also makes connections with the pterygoid venous plexus to the deep facial vein, and which passes backwards over the buccinator. This is what I told you during the cavernous sinus, right? Dangerous area of the face. So dangerous area of the face here is the upper lip, okay, near the philtrum of the upper lip. So septum of the nose and adjoining areas of the cheek can also be affected. So the facial vein, when it communicates with the cavernous sinus through the emissary vein. So how it is connecting? So facial vein, the deep face is connected to deep facial vein to pterygoid venous plexus. And from pterygoid venous plexus through the emissary veins, it goes to the cavernous sinus. Okay, so all this facial vein as well as its communications, okay, they do not have valves. You should keep it in mind. So there is no interrupted passage of blood to the cavernous sinus. So there is uninterrupted passage of blood to the cavernous sinus. So squeezing pustules or pimples in the area of the upper lip or side of the nose and cheeks is dangerous. Okay, so that is why even nose, that is the dangerous area of the nose as well as dangerous area of the this thing. What is that? Face. Okay. So we'll reflect on this question now. 30-year-old man comes to OPD with inability to close the eye, his left eye, tears overflowing on the left cheek and saliva dribbling from the left angle of the mouth. So what do you think this case is? It is a case of what? Bell's palsy, isn't it? This is not able to. So whole upper one half of the face is affected on the left side. So is it a supranuclear or infranuclear? It is infranuclear lesion because the whole half of the same side is affected. Okay, which is the dangerous area of the face? Dangerous area of the face is named because of connection of the cavernous sinus with facial vein. Through which vein? Through which vein it goes? With the facial vein is through the deep facial. Okay. Infection in the dangerous area of the face usually leads to, okay, infection in the dangerous area of the face. So it will lead to the cavernous sinus thrombosis. Yes. Okay. So with this, we conclude today's class. So until then, next time. So here. Okay, so thanks for watching Auricle. So for more contents, you can follow the social media handles like the Instagram, YouTube, Facebook, and Telegram. And you can, if you haven't yet downloaded the app, you can download it on Google Play and App Store and on App Store, where Auricle is providing. You can, there are loads, there are all these live recordings of all the live classes, and you can as well, links are shared there. You can uh, attend the classes regularly through that, okay, through the app. So download it now in case you haven't yet. Okay, thanks for watching again. So until next time.